now, isn't it, Zoe? So I'll just get my slides up.
Thanks, Stuart.
You'll have a little option saying continue, or an option to leave if you don't want to. It won't capture you, so, but it might capture your exchanges if you have questions, etc. So I'm just going to share my slides and let's get going. Okay, can you all see my slides? No?
Not yet. No.
Not yet, Will.
There's a little bit of technical things. Oh, there we are. Can you see them now, everybody?
Yeah.
Yeah.
Brilliant. Okay, everyone. So if you could all be mute if possible, just the old background noises or children in my case that might occasionally come in. Welcome, everybody. So I think a lot of you joined in the last two sessions. This is the third of our final installment of this little masterclass series, which is a real taster session in what the NHS does in the context of trying to spread and scale your innovation, be it technology or a practice or an approach across the NHS and social care. This is a taster for what we're hoping to do or will be doing with the Smartline programme over the next 3 years, which is going to be a real focused programme for organisations that are registered in Cornwall that are part of the Smartline programme. The Smartline project is a great coalition of partners led by the brilliant University of Exeter with Cornwall Council, Coastline Housing and Volunteer Cornwall and ourselves, and it's funded by the European Union to support SMEs that have got potential products and solutions that focus on health and wellbeing. So some of you will be Smartline projects, some of you might be outside of Cornwall, and you're absolutely welcome to be here, and you may be interested to connect and even maybe register in Cornwall, which would be brilliant. So without further ado, this last session really is about navigating the NHS. I mean, it's a taster. We're going to do our very best to give you a glimpse of some of the opportunities, some of the things to consider when engaging the NHS, and give you a little sense of the sort of support system, including ourselves, which my brilliant co-host Stuart Monk is going to present in the latter part of this session. Say hello, Stuart. Are you there, Stu?
I am, sorry, Will. Hello.
Brilliant. Okay, great. So we're going to start with, we're going to do a bit of an introduction with myself, so talking a little bit about some of the enabling barriers, and then there will be, as tradition, a little bit of a breakout to give a bit of a breather and to get an opportunity to connect to others. So that's going to be facilitated by myself, Stuart, and Emma Seymour from the Smartline team, and that will be set up technically by our brilliant technician, Zoe, who will do that in about 20 minutes or so time. So I'm going to start with cake again. For those that would be fed up of cake analogies now, this was a cake analogy that Sarah Robbins and Hayley used in their last two presentations when we're thinking about the ingredients of our spread project, the thing that we're trying to spread. I also thought it was quite a useful metaphor to say, yeah, cracking the NHS is a piece of cake, isn't it? Well, probably not. So as a metaphor. And I think this is another slide just to kind of recap from the last two sessions. You know, we really talked a lot about those first three stages. So thinking particularly at what stage are you in your journey? And that often we think we're spread ready or ready for spread across multiple sites, when actually often we might be still at pilot, and in some cases we're still at prototype, and that's okay. And I think we've got a real range of people in the Smartline programme and those that have participated in these calls across those first three stages. So I'm going to start really quickly. As I say, I will not do this subject justice in the next 20 minutes that I have, but hopefully I'll give you a bit of a glimpse, a little bit of a taster, and some of the kind of key things in our learning as an NHS, who are principally here to help you as innovations and innovators navigate the National Health Service, and also alongside that other public bodies in the social care space and beyond as well. But our primary interest and focus is the National Health Service, because we're completely funded by the National Health Service, NHS England, the Office for Life Sciences and NHS Improvement. It's a huge opportunity at a really critical time in its history, obviously with COVID-19 very much still with us, and a huge structural challenge for our service at the moment, as we all know, as we all knew through the winter and through the summer and the pandemic, etc. It is the biggest healthcare delivery organisation in the world, and it's extremely complex and bureaucratic. So hopefully I won't put you off in the next 20 minutes, whether we're working with NHS again. But actually, in some cases, we need to really set this up with the caveats that it is really complex and it isn't one organisation. You can't sell to the NHS. It's an extremely complicated web of interconnected entities and bodies. That quote down there, 85% of UK entrepreneurs feel that NHS procurement process, well, it's true. It's hugely unwieldy, and hopefully I can demystify some of it in the next 15 or so minutes. And particularly in the next, if I haven't put you off from working in the NHS and you're still motivated and excited by it, because you should be, then Stuart will pick up a little bit in terms of what support is out there to help you navigate some of this complexity. NHS England alone has many component pieces. It has a lot of, as I say, a lot of complex elements to it. And depending on your product, your service, your solution, will be, which part of it you need to navigate. But often you need to navigate multiple parts of it, both at a local and sometimes at a national level. If you want a really lovely intro, some of you will have seen this already. For those that haven't, I really recommend the King's Fund's fantastic alternative guide to understanding the NHS. And it's quite useful to see, there's a couple of films they've done in the past and they regularly update it. And I really recommend King's Fund as a key influencer in the National Health Service in terms of understanding trends and behaviours and policy developments. But it's a really nice kind of sort of intro into it. As you can see laid out there, it's extremely complex, lots of key parts of it. And cumulatively, it spends a lot of money. 27 billion a year is spent on products and solutions within the NHS. And it gets bigger every year. And particularly in the current context, alongside all of this, our deficits are going up as well. In terms of understanding some of the drivers, which I'll talk about in a minute, deficits, the challenge of spending money and doing more for less is just getting harder and harder and bigger for the National Health Service. But as an opportunity, it's a huge spender and purchaser and buyer. How does the NHS choose what to buy and how? As I said, it's 27 billion specifically spent every year on goods and services. Out of that 145 billion that is the annual budget for the NHS. There is an overarching strategy. It is a public body. There are lots of rules, there's lots of regulations and policy drivers behind it. The Department of Health, where everything goes back to, has a procurement strategy, and the heart of that is delivering taxpayers' value. This is taxpayers' money. Thus, it is incredibly important to know that we're creating value for money. I mean, it gets you kind of grow hoarse and a bit boring saying it, but at the heart of this is cost effectiveness, which is why for us, it's so important to understand how much your product costs and how much it might save, or how does it compare to the alternative. But at the heart of the procurement strategy that you can find if you want to in the Department of Health, there is a huge emphasis on supporting innovation and stimulating growth, supporting SMEs like yourselves, social entrepreneurs, social enterprises, voluntary sector organisations that have ideas. That really is at the heart of the procurement strategy as well. There is a real need and desire, doesn't always come across, doesn't always feel like that way as an SME, but at the heart of it, there is a real drive to try and support innovation and stimulate growth. And we're part, as an NHS, funded by the NHS, part of that initiative to try and stimulate and support more creative solutions coming forward. At the heart of all of this, though, is delivering better care at the highest quality for patients and communities. So you might be able to deliver something very cost effectively. It might be really innovative, but if it's not improving care for people from the care that they have received or the care they're currently receiving, then there really isn't going to be much progression for you. As I say, it is an interconnected web, and it can feel quite, at sea at times in terms of where to go to. But like I say, you can't approach one part of the NHS, say a clinician who's quite interested in your innovation, without considering the other key interconnected parts of this jigsaw. And it is putting a little bit of a jigsaw together when you're trying to navigate the NHS. When you're trying to navigate that jigsaw, it's really keen to understand, well, what are the key routes to buying? Like I say, it can be really bloody confusing, and where to go, where to get, where to start. And it isn't the same for every product, solution, idea that you might have. There'll be different routes to market depending what type of products that you might be developing or that you have to offer. In some cases, it's fine to sell directly to, say, an acute trust or a GP. That might be within their gift, within the rules and policies to do that. And it might be something that a trust can do as part of its overall contract within the clinical commissioning group. And you can speak directly to a potential clinician, but then they're not necessarily going to be the buyer. Somebody in the procurement team will then have to buy that, depending, again, on the evidence that you need, the risk, the level, etc. Selling through the NHS supply chain, well, I suspect for many of you this won't be relevant, but for some of you it might be. This is national networks that have been created to buy things of volume, often food, services, estate management, etc. But it's useful to know all of the different routes and then looking back at the product that you have to understand which is the right route. And there are some great guides out there and things that we can signpost you to get into the detail of some of these routes to market. There may be a need for acute trusts or GPs, etc., to come together to group purchase. There might be collaborative arrangements that people have created. Again, it's completely contingent on the product and solution that you have that might merit one of these routes. There are national frameworks. The HSN is on a national framework. Bloody hard to get onto some of these frameworks, but there might be frameworks that you can then join. And then when commissions come out, they'll only come out to those that are on the supplier framework. Again, there's lots of information out there that you can find about the different frameworks that you might join. Often, particularly frameworks are relevant for consultancy services or innovations that are service driven. Could be, coaching, consultancy, etc., etc. And then there are government tenders and contracts, all of this, unfortunately, which is why it gets very bureaucratic, which is why 85% of entrepreneurs say it's so bureaucratic. There is a lot of course, tenders that are at the moment obviously overseen by European Union, and there are certain levels and thresholds that you need to abide by in which to win that tender and that contract. Again, there are lots of resources and agencies that you can connect with that have particular skills and capabilities in tendering. I used to, when I was running an SME and an organization, I used to outsource some of that because it can be very time intensive and there's a real skill to navigating tenders. But these are the 5 classic routes to the market. Now there's questions and things popping up, so we'll definitely make sure that we have an opportunity to pick some of them through some of the breakouts as well. But do throw ideas and things and questions, and we'll try and get to them throughout the session. So what might the NHS want? Why might the NHS want your products? Well, this is getting to the nitty gritty, really. Again, thinking about that overarching strategy, the overarching drivers around procurement. At the forefront, it's the clinical benefit. Now, your innovation might not be clinical in nature, but it's really important within the NHS to understand, well, what improvements this is going to make ultimately for patients. Is it going to reduce harm? Is it going to improve safety? Is it going to improve the quality of life of that person? That's got to be at the center of your work. So really be able to, and it goes back to the logic modeling we talked about before, and that's why it's so important to really understand the outcomes, the impacts of what you're trying to do. And then obviously the efficiency. You know, it's hard to find many innovations, is it, Stuart, that deliver incredible benefit and yet don't need to show some form of efficiency. If you're actually making it more inefficient because of your product, well, I would wonder if it is actually better for the patient. But if it's more expensive than the alternative, but it's delivering better care, then you need to really be able to extol the benefits and the added value of what you're trying to do. But it's a part of the jigsaw will be trying to crack that cost point, so trying to be as either at the same price as the current product, but probably most of the time cheaper, at the same time delivering better value. It's a real jigsaw that you have to try and get right in doing this. And then obviously the priorities. Now this really gets into that point, and I'll come into it a second. What are the priorities? What are the motivations for the different stakeholders that you need to talk to, depending on your product? Now, if that hasn't completely put you off, there are a few other hurdles and things that will be in your way, and it really is a bit of a race here. And you've got to, it's not for the faint-hearted. You've got to have a lot of energy for this, and you need to really thus then focus on what your unique proposition is if you need to overcome some of these hurdles. So again, we talked about the budgets. I won't wax lyrical about the restriction in budgets, but it's becoming, we're not keeping up with demand. Our budgets haven't really gone up in the way that perhaps they have in the past to stay with demand. So we're going to have to face that as an innovator head on. That we're working with limited resources, and that's only going to get worse. There are, and I can't avoid this, there are long decision-making processes. And again, it's not for the faint-hearted. It's an endurance race. You need to recognize and build that in to your thinking. And thus that means you need to be even more focused, even more structured, what you're trying to do, because the time period, even with the best will in the world, and even if the commission, the clinicians, the patients, they all want it, the reality of these processes is that they are often very long, very time consuming. So you need to have a lot of energy, and you need to build in this time factor into your development process. And there is a lot of regulation around the procurement, around the commissioning, but then the clinical elements as well. That if it could be a medical device, there's lots of regulations around that. It could be a digital medical device. Again, that's we're getting mature in our understanding of what the processes are around digital devices. But there is support out there, particularly around regulation that you can access. And all of this, the NHS wants to see rapid benefits. So being able to really think, okay, I mean, my background is early intervention prevention, trying to sell prevention to the NHS when often the benefits take 4 or 5, 6, 7 years to accrue. You need to then thus think, well, what are some of the immediate benefits that I can start to communicate that will give them, some hope that these benefits will accrue at some point in time? Well, what are the quick wins that we can start to generate? There is a lot of siloing, and one of the big drivers, as I'll come on to my last slide in a minute, is around integration. We're seeing those silos starting to be closed down, which is fantastic, but it can be quite frustrating. And that, you're making a saving over here for one part of the system and they're really happy, but actually someone down the road has seen their service impacted negatively, and no one can decide in all of that who should buy it, particularly in prevention. When it might be actually everybody's going to potentially benefit, but no one really wants to take the responsibility. And it can be quite frustrating to try and navigate that. And then sometimes you'll have a local system that really wants something, but actually that goes against what the national system wants. There might be certain regulations or guidelines or procurement structures that I talked about, which make it quite frustrating for local partners. Or there might be stuff that the national people want. We often see that. We often see a minister come up with a device and say, I want the whole of the NHS to do this now. And the local system say, well, I don't want to do that. I don't see the evidence. I don't believe in it, et cetera, et cetera. So that can often happen. I think key to your work is really understanding the decision-making unit around your innovation. And that is inevitably never one person. That's often a collection of different individuals that you need to start to really think about. So your decision maker, or sorry, your buyer might not be the person that's ultimately going to make the decision. There might be a national decision-making process that's going on that you need to be connecting with. The buyer might want something, but actually the clinical expert says that the evidence isn't there, which is frustrating to the buyer. Or the buyer or the clinical expert might want something, but in reality that the buying capacity isn't there. So you need to understand who the buyer is, who's going to buy it. Is it the trust directly? Actually, I can just go to the trust. Do I need to engage the clinical commissioning group that's thinking about the wider strategy in a region? And who are the gatekeepers? So I've got the buyer, I've got the decision maker, but I can't get to the buyer because I can't get through reception, or I can't get through the procurement process. I know the commissioner wants me, but I can't tick this box in the procurement process. So you need to understand who are the gatekeepers, what's motivating them. And fundamentally at the heart of all of this is patients and users. That could be the staff as well. What's the desire? How is the user using this service? An innovator that myself and Stuart worked with a few years ago was called Personalised Alarm Watch, and they came to the Southwest and we facilitated a session with users with a frail and elderly that wanted this alternative to the pendant, and it was absolutely transformational in how they designed their product. All of their assumptions were obliterated because users were really engaged in their thinking, and it changed their working assumptions. Who are the influencers? Now, the NHS is an influencer. We have some influence, so engaging people like us, but there could be academics, it could be clinical experts, key opinion leaders that you need to try and really access. And I think Stuart will talk a little bit about that in the afternoon. I don't think we think about the people outside of the buyer that can influence the buying behaviour as much as we should. And that's probably a lot of our learning as an NHS that we've really sort of absorbed over the last sort of few years. And who's the initiator? The people that are going to start this off. It might not be the buyer even. It might be somebody who knows somebody that can just initiate a conversation. Often we initiate conversations, but it's thinking about all of the different people that might be part of that ultimate decision-making unit. It's never just one person or the buyer necessarily, or a decision maker. So hopefully that hasn't completely confused. Let's give you a little bit of sense. This last slide, once you've figured out who your decision-making unit is, who's the kind of core group of people that are going to help you get your product and service landed into the NHS in a sustainable fashion, what's motivating these key partners? What's the motivation? So I've identified that because of my intervention, it's about keeping people out of hospital, and it's it's in the prevention space, and it actually might be politically at odds with, say, some of the acute provision or whatever. Then I'm going to have to engage the CCG. So what's their strategy around prevention? What's their sort of commissioning intentions over the next few years? They might really want it, but it's going to be an 18-month process. So I need to buy that in. I need to factor that in terms of how I start to think about that on these key strategy documents I need to read. What's the strategy of the acute trust? What's the kind of key motivations within their organisation? Even if they're not necessarily going to be the key buying mechanism for you, it might affect their practice or impact how they work in the system, and they could be a potential blocker. So you need to think about how you engage them, or what motivates them. What motivates your primary care teams? Some of you might be working in that space where we haven't got enough of them, massively under pressure. Classically, we're not recruiting enough GPs down here. So it's thinking about some of the structural issues that, say, our particular friends within the sort of GP primary care system are facing at the moment. Councils, families, care, they all have different motivations. And it's about understanding what drives them, what drives their influencing behaviour, what drives their buying behaviour, and who you need to start to think about. Gosh, there's a lot there, isn't it? Again, like I say, it's not for the faint-hearted, this, but I think it's really important to understand the kind of the complexity and the dynamics of how all of these different components impact. What unites all of these key people I've got in front of you here is improving care and getting ultimately better value from what they had before or what they currently use. That's the kind of, if there's one thing that binds us, is that we all care ultimately about making things better. It might not always appear that way, but that's ultimately the driver for all of these key elements. I'm not going to dwell on this, but there's always change. So again, I think sticking in touch with the Nuffield Trust, the King's Fund, my favourite, the Health Foundation, I think they're fantastic. Reading what they're producing, understanding the different structural changes. One of the big directions of travel at the moment is integration. So we're seeing even more acronyms come out at the moment. We do like an acronym. Some of these you'll be familiar with, the STPs, the Sustainability and Transformation Partnerships, the Accountable Care Systems, the Accountable Care Partnerships, the Primary Care Acute System. What this is telling us is that there is a real driver to integrate the system, because we know it's been too bureaucratic, we know it's been too siloed, and we know ultimately that we want to deliver better value, and that means preventing people ultimately going into hospital, preventing people from needing it unnecessarily. And that's about investing in the whole system, bringing all the different key parts of the system: primary care, acute care, social care, importantly social care, and also other parts of the system, housing, employment, etc., etc. So there is a real drive in our systems, particularly here in Cornwall. We're going to see the integration of the acute, the mental health, the community, the CCG increasingly, and this classic split between the commissioner over here and the provider over here. We're going to see that again amalgamated. And those that have been around long enough will remember that we do seem to go around circles in this stuff. It is a bit circular. But that's it. And again, like I say, do check the King's Fund, do check the Health Foundation. They have some fantastic infographics and places to look at. The last two slides here, we've talked a lot about this last week with Hayley McBain, Dr. Hayley McBain, around evaluation, formative, summative. Whatever you are going to do from here on, be prepared to be challenged. But really understand the level of evidence that you need versus the risk that your innovation is going to take. Because some innovations that might be here in the audience might be quite low risk and thus don't necessarily need the same level of evidence. We do have a bit of a myopicness towards randomized control trials, but that's because classically in the NHS it's been about drugs, it's been about things that could potentially deliver a lot of harm and have a lot of risk involved. Not every innovation necessarily has that level of risk. A business case, a good well-rationalized business case with maybe an article that describes the benefits could be enough and sufficient to allow you to get contracts, but in some cases you're going to need peer review publications, and you might even need a randomized control trial to follow through. We talk a lot about real world evaluation, which a lot of what Hayley was talking about before, which is, in the real world. It sounds quite patronizing to our colleagues in the clinical community, because that's not suggesting that, but it's depending on the type of innovation, it might require actually a bit of a real world evaluation that is less intensive in terms of investment and time. The logic model is a great thing to work on. And again, not to push that from last week, but I think if you're going to choose a particular mechanism to understand the benefits and design and evaluation, then logic models are a great thing. I'm not going to dwell on NICE. There are too many acronyms to talk about here, but NICE are really important. The National Institute for Clinical Excellence are a really important influence, a key opinion leader in the NHS, and they produce guidelines and advice and guidance on innovations. And even if you are, say, a community intervention that is about, linking volunteers to peers in your community or whatever, you think, what NICE mean to me? Well, there is guidance in NICE on that. You can see there's a whole range of NICE guidelines on social prescribing and early interventions and things like that. But they are catching up with that world. But if you're a medical device, if you're a digital device, a NICE the reality of your innovation that's going to potentially impact patients negatively, positively, whatever, then absolutely NICE needs to be in your thinking. And there could be key opinion leaders, influencers within the NICE groups that you can identify behind a particular area that actually could be really useful for your work and engaging them. I'm not going to dwell on this because Stuart's going to pick some of this up, but just linking back to the previous presentations, this is a lovely way of starting to think about some of what I've talked about and some of the tactics and methods of engaging the National Health Service as you go forward. And we go into all of these slides and all of this stuff much more in depth in the fuller, longer term format that we're going to design and deliver with the Smartline project going forward. If I could just final slides from me. Sarah used this in the first session that we did a few weeks back. The traditional way in which we often confront this subject is, how can I get the NHS to buy what I've got? Why aren't they buying it? To this question, which is, how can I help people in the NHS do what they want to do? And that's probably the final thought from me, which is really understanding your demography, really understanding your patient group, really understanding the motivations of the buyer, the influencer, and the context in which they're working in. So I'm going to pause here now, take a breath. There's quite a lot I threw at you there. You'll have the slides, the recording as well. So hopefully that gave you a glimpse of some of the things to think about. We have a small opportunity now to just have a quick breakout. I've obviously overgone for a few minutes, so we might not have that much time, but we'll try and do about 10 minutes or so, and then we'll hand over to Stuart to give us a real sense of the support that's out there to help you navigate the NHS going forward. So Zoe, you're going to put people into, I think, 3 groups. Is that sufficient?
That's right,
yeah. And the question really will be, one of us facilitating is a bit of a breather, introduce yourselves and think about the enablers and barriers that you've faced so far in navigating the NHS, and what other public bodies that you're trying to engage with that might be the buyers of what you're trying to do. So Zoe, if you want to hand us over now, and we'll get into our groups.
Okay, yeah, I think we've got 10 minutes, haven't we, for the breakout. I'll send you all through in now.
Good morning, everybody. Hello.
Hi.
Morning. Yeah.
Good to see you all. Thank you for joining Will and I this morning. Barriers and enablers around the NHS. I'm sure some of you have got some experiences of that in and around your innovations. Is there anybody that would like to start with any reflections that they've got on that, or anything else that you've seen this morning?
I think from my
Silence.
side, I'll just kick off. But sorry, yeah, we've been very thankful to be working with Smartline. I think we didn't know anything about the NHS at all, and thanks to the guys there, they've actually helped us sort of go through what is, well, I mean, again, as Will was saying this morning, a very complex and minefield of who to target who and so on. So I have to say that we wouldn't have done it without that level of knowledge from the guys, to be honest. So
that's good to hear about the Smartline project and Jeremy and the help that that's provided you with. It is a minefield. I think if you can yeah, if you can just build your understanding of the system as best you can before you start wading into it, then it definitely helps, but it's a difficult thing to do, I have to say. Rebecca, you were going to speak as well, sorry.
Oh, no, that's fine. It was just to kick it off, but I think very similar to Jeremy. I work for a project called EPIC, which is around e-health innovation in Cornwall and the Isles of Scilly, and it's very similar. I think the SMEs that are coming through often struggle to identify who it is kind of most appropriate in that context to make the final decision. So you could be chatting to clinicians, everyone else, but like Will was saying, they might not be in that position of power ultimately, I guess, to make that final decision. And then you could become frustrated that you've spent all this time, energy and resources and speaking to ultimately not the decision maker.
Yeah, really helpful. I think one of the kind of common trends that we find is that it can be really easy to get a clinician interested in what you're doing. It can be a lot more difficult once that clinical voice tries to take that business case, or well, not the business case, the innovation into their sort of layers of middle management and yeah, all of the bureaucracy that sits around that can be really taxing, and ultimately, you know, what the clinician wants to do won't necessarily be the thing that happens once that business case is starting to be written. So yeah, but yeah, fascinating. Any other reflections from anybody?
I think that, I mean, I run the digital and e-health test bed in Kernow Health in Cornwall, so I deal with real world evaluations all the time of digital and e-health products. And one of the keys that most people miss is to actually ask the clinician at the very start where the procurement would come from and who we've got to talk to, and get them to massage the routes and network for you. Because the network I've got throughout the NHS in Cornwall is because I've decided to build it. And some people don't realise that that person that they are speaking to, whilst they are so enthusiastic and waxing lyrical about how brilliant it is, have absolutely zero budget responsibility. And that's where the secret comes in, is finding the budget responsibility at the get-go.
Really helpful, Gary. Some wise words there as well. We do, as an AHSN, we do often shudder when, you know, an SME comes to us and says, oh yeah, you know, I've got a pilot started with this clinician over here, and we've got another pilot starting over here with another group of clinicians, and they're all really excited and enthusiastic, and you know, and they're enjoying using the product. And it's like, well, you know, have you charged them for that? Well, no, it's all, you know, it's all available for free at the moment. And often what you find are people that want to play with your toys in effect, but not necessarily commit to any purchasing, because as Gary said, they're not plugged into the right levels of budget responsibility or change programs or networks, or, you know, part of their sort of clinical decision making. So yeah, interesting. Anything else? Yeah, Tim, Sarah, Patrick, anything to add from your side?
I think my experience of dealing with the NHS is it's a very solid brick wall, and they really struggle to find right people. I spend my time, I lead a team that's looking at keeping people warm at home. So looking at, we've had projects like, can we do boiler on prescription? So talking to GPs, so when they're meeting people that potentially are in fuel poverty, well, we can get involved. And there's just a complete disconnect. And some of my experiences around the difference between cashable and non-cashable savings, because if we're doing early prevention work, well, that may take some pressure off, but it doesn't actually turn into money necessarily.
Yeah, but really helpful, Tim. Will spoke about the challenges still around a system that struggles to think about prevention and preventative innovation, because it has this need to realise tangible cost benefits within a year, ideally, from the NHS's perspective, which for you then as innovators is really challenging, like especially if you are working on something that's at the preventative end, preventative end of health and social care. Yeah, really difficult. I think Will had that slide that showed some of these different acronyms where you're seeing the system join up: sustainability and transformation partnerships, and integrated care systems, STPs and ICSs are probably the two most common, where you're seeing social care align more with acute hospitals, community and mental health providers, and primary care in regions, just to try and think through change a bit more collectively and transformation. And there are some opportunities there, I think, for innovators, but it's still really challenging. You're right, Tim, really challenging. Sarah or Patrick, anything to add from your side?
Yeah, well, I used to work for the NHS for quite a few years, and yeah, I've been involved in various research projects, working within either one NHS organisation or between several national ones. I think for me the main barrier is the sort of ethics, regulatory approvals, and also how that varies between different sites. And I think that takes a lot of time to navigate. It's just, yeah, the time everything takes, really. And also sort of, even within a particular trust, it's lack of communication between different departments. And I think that's probably not so much of a problem these days, but that has been in the past. And yeah, just lack of awareness of people, sort of what the processes are, who you need to go to, and who's sort of responsible for various approvals.
From my perspective, I did a demo of our product to Newham CCG, and on the call was between 60 and 80 people on the call. And they had to have a special software. I was like, why do I have to download this special Cisco software for this call, expecting there to be a couple of folks on there? And there were so many people on there. Like, I don't have any insights. I didn't say anything. I mean, I don't know. I'm trying to learn like how to best do it. It's basically massively overwhelming, and I feel like one of the things I'm like thoroughly questioning is like, should we even be selling to the NHS? Is that the right market for us? We have something which is definitely helpful, and there's a strong value proposition. However, it's just so easy for things to get stuck, and it's so easy for even very good things that will be very incredibly helpful, which seem like a no-brainer. There's just so many things that can just emerge, and you just need one person to say no, and then it will get stuck. So from my perspective, like, if I'm completely honest, like, what am I looking at is like, how can the NHS be one revenue line for our company, and then what are the other ones that we can start to like build a business around? Because from what I've seen, the time taken and then the what you will get seems quite difficult. And like, Stuart, to your point around like trials and clinicians being excited about it, like, that is almost a vanity metric. It makes you feel very good when people want to be trialing and you're getting amazing feedback from the wrong people. And it's not that they're the wrong people, it's just they're one of a chain of people. You know, you might have 60 people to convince, and there might be 2, and there's 58 others who are going to be involved in buying something. I'm like, I need to learn like what is the way to do it better. As I think forwards to like what we might do, I mean, I think there's a bit of like, there's 2 tracks. Like, what do we do ourselves? Like, and it's just like marketing that we're going to do ourselves. And then I think for me, like, more strategically, I'm thinking more like channel partnerships. Like, who's already got a contract with the NHS that we can then be like part of, if that makes sense. That's one of the areas I think that might be a way. Because I think when you get incumbency, then you probably are in quite a good place.
It's really really helpful, Patrick. I think you're thinking of all the right things. Whatever you do, don't think that the NHS is your only customer. You know, think about how else you might sell your product. With the NHS or social care, as one of or 2 of potential customers, because it is really challenging. And your webinar example gives you a really good insight into how many people can be involved in a decision-making process. In a nutshell, it's so complex, and often everyone wants.
Hello all. It's always brutal, isn't it? There's not enough time in these things. So, but it was good to get a flavour there of some of the challenges and opportunities from those that did get to speak. I will say, as I said, in my group, we're going to do a longer version of this. Several workshops for a group of people that really want to go on a bit of a journey with the Smartline program. So you'll have more opportunity to connect. So sorry that you didn't all get the chance to share your thoughts. Stuart, was there any reflections, Emma, that you wanted to share, or should we?
Yeah, I mean, look, we covered a lot of the usual suspects, Will, you know, clinicians that are really interested in piloting something but don't have any budget responsibility to make any decisions. Patrick spoke about a webinar that he joined in Newham where 80 people were suddenly online hearing him talking about his innovation that he wasn't expecting. Yeah, fascinating.
Yeah, that's quite scary, isn't it?
Issues around prevention, you know, preventative innovation, still really difficult for the NHS to get their, you know, heads around. So yeah, good conversation.
I've got a few people that are going to run the next masterclass, actually, some real experienced heads in our group around selling. And one of the things that came up was just timing for me. You know, sometimes it's just not the right time. And often innovators are kind of ahead of the curve naturally, aren't they? They're kind of, you know, they're pushing the boundaries, they're radical. And sometimes we're not ready for it. And then at some point we are again, you know, and sometimes, you know, you meet that, sometimes you don't, because you might have, you know, moved on by the time they're ready. But it's timing was a big thing that came out in our session.
Yeah, well, same with that, the key, how the time it takes. But a key thing that was coming out was actually some people will have made connections within the NHS, but because it's so disjointed, that does not necessarily mean that's going to help you with, you know, so you might have connections in Cornwall, but if your idea resonates in Scotland, that's not going to help. Also the fact that if they then change the framework, so if you've built up that relationship and that changes, and also people changing their roles, so you've built up that relationship, so that seems to be a kind of a big kind of barrier and a concern to people, that you've put all that effort in, but yeah, a change in role, a change in how the frameworks are, can be detrimental.
Absolutely. I had for the Kenai, my little jigsaw thing, I had Wales and Scotland in there. Only things like supply chain actually live for England and Wales. You'll have a separate supply chain for say Scotland, and key opinion leaders might influence across those spaces, but often, you know, there'll be separate devolved strategies around procurement and decision making. So yeah, no, it's a really important one. All right, Stuart, over to you. So for the last bit of the session, really to talk us through, if we haven't all been put off by my session, what support's out there to help people navigate the NHS?
Great, thank you, Will. Yeah, we've still got all 27 people online, so that's good. I'll share my screen rather than having to keep saying next slide, please, if you're happy with that. I've got the slides. Can you see those okay? Good, thank you, Emma. So just for the next few minutes, I'll give you a little bit more insight into who we are and what we do, and talk about some of the national programs that all 15 AHSNs support that enable innovators to, well, in some cases draw down funding, in other cases tap into coaching, mentoring and learning support to try and ultimately put you in a position as an innovator to scale your innovation more effectively. So down here, Southwest AHSN, this is the area that we look after, quite self-explanatory, Somerset, Devon and Cornwall, and we work with all of the NHS organisations and more with local authorities and the care sector more generally across those 3 counties to try and do 3 main things around our innovation engagement work. Understand what's happening locally in terms of challenges, that understanding context point that Will mentioned, really important for you. You know who's doing what and where the challenges and needs are in terms of the NHS and social care organisations in the Southwest Peninsula. That's a key thing for us too. We try to tap into that. And then, you know, identify and work with innovators and try to get those innovative practice, products, technologies, ways of delivering services spread across our system to improve patient safety and hopefully enable as many of our 2.3 million residents as possible to receive equitable services from all of our NHS providers. And through all of that, you know, whilst we're working with our NHS teams especially, do what we can to embed a good culture of learning, of quality improvement, of measurement, of receptivity to innovation. These are all key things for us as an AHSN that we want to build along our innovation, adoption and spread journey. And the innovation exchange part of our work that Will touched upon earlier. It's commissioned by the Office for Life Sciences. As I've kind of outlined in that previous slide, they ask us to do these 4 main things: understand local needs, provide this signposting service to our innovator community, support real-world validations actively, and we have funding to help do that for the most promising ones, and we try and build those partnerships with our system stakeholders and you as innovators to gather that real-world evidence to support adoption and spread. And then once we've done that, support the adoption and spread of proven innovation, both locally and then working with you, the likes of yourselves when you're at the right point, hopefully nationally too. So to touch upon some of the national programs that we support, and some of you might have heard of these already. And as an NHSN, we're really keen to support you if you're interested in getting involved in some of these programs. And I've got a slide at the end that outlines the type of support that we can provide. But to go through the programs in turn, first one is the Small Business Research Initiative for Healthcare, SBRI. There's SBRI is an Innovate UK brand. The SBRI healthcare programme is actually funded by NHS England. So it's NHS England money that's made available to innovators to develop the new products and technologies that the NHS thinks it needs. And as NHSNs, we're really pivotal to the way that this programme is delivered and trying to, understand needs, turn that into a briefing document that then innovators can respond to, sit on the panels that review the innovations, and then ultimately award the funding. And if you're successful at phase 1 through this programme, you can get 100k to test the concept for a new product. And then if that goes well, you can apply for up to £1 million to take that new product idea into prototype mode. So this is quite early stage, and it's good, we think, that the NHS is thinking in these terms. It does provide this funding to support new products, as well as providing programmes that support things a bit further down the line. One of which is the NHS Innovation Accelerator programme that, again, all 15 NHSNs support. The closing date for the current programme is this Friday. Will can remind me of the themes for that at the end because I've forgotten. I think there's a mental health theme, Will, isn't there? Can't remember what else we've got as far as those 3 key themes go for NIA this year. It's run by our colleagues at the UCL Partners HSN in London. It's really looking for innovators and innovations that have started to secure some traction in the NHS and have got lots of evidence, but where the innovator and the product might benefit from some more mentoring support, some more learning, some more peer-to-peer learning with some other innovators. So yeah, the programme's unique. It's actually as much about the innovator themselves and their journey as much as it is the product. So the support isn't necessarily financial, but it will plug you into lots of AHSNs and hopefully help you grow adoption and spread whilst learning as an innovator for the course of the year that you're on the programme. And it does open lots of doors. Being on the programme now brings kudos. And it's a big thing for us down here. We do what we can to support our local innovators on the NIA. And then the final programme that I want to mention is for, again, products and technologies that are really, at that stage where they're getting lots of NHS uptake and traction, that might benefit from some more pump prime funding centrally, especially to overcome local procurement hurdles. And that's the Innovation and Technology Payment Programme that now consists of something like 20 different products and technologies that are being added to each year, although we haven't had any new ones yet this year, but we're expecting a couple of medicines to land on the programme this year. And for us as AHSNs, we support this product, this programme locally by engaging with our commissioners, our providers, to try and raise awareness of the programme, make sure that they know which products are being funded centrally, just to make sure that they can tap into that central funding opportunity, whilst in parallel developing business cases to support longer term adoption. So in terms of the help that we as an AHSN can provide for those 3 programmes, you can summarise it as such through these 5 bullet points really, and this is for you as innovators to bear in mind. We can check in with you before you put lots of time, effort and energy into writing that first application form to make sure that we think you're suitable and that you and your product are at a suitable stage. We can help you build partnerships with part of the NHS to try and help do the prototyping and piloting work that's necessary, especially for the SBRI programme. We can offer that brokerage. We can help you develop your application whilst we do review the applications as well, Will and I are becoming quite adept at building an imaginary wall between us. So if Will's supporting applicants and I'm reviewing, then we don't really talk to each other too much, because that would jeopardise the integrity of the process. But we do make sure that we offer both parts of the service. We can give you pitching practice, and we've done that to quite good effect to prepare you for the interview panels. We know the people that are involved, we know what they look for, and we can really help prepare you for what's coming in those Dragon's Den type pitching sessions for these programs. And then we can provide you with ongoing support once you've landed on the program. And if the timing of the program isn't quite right 1 year, we can put you in a position, hopefully, to prepare next time round. So quite a lot that we can do. So please come and talk to us either through the Smartline team or just come to us direct. A couple of other programs that again we try and plug into that NIHR runs. So the Invention for Innovation program looks for products that are probably in that, I suppose, what you'd call the valley of death, readiness level rise. They've come out of piloting, they're not quite securing any adoption yet, and they're looking for some more sort of evidence generation, and ultimately perhaps investment. And the I4I program tries to prepare products and the innovators for that, really. But yeah, just to try and help you, push you on that journey towards adoption. I think that's almost it. Just to remind you all of some of the spread messages that you've kind of heard embedded through these sessions, I think, but that we really live and die by at the AHSN now down here, that we really try and impress upon innovators. So understanding what it is that you're trying to do, your aim, your intentions, the key ingredients of the thing that you want to try and support in terms of adoption and spread, your product, what is it and how it's going to help. Understand the context. I touched upon this at the start. It's a recurring theme through some of Will's work. Understand what you're walking into. What are the priorities? How can you help people do what they want to do rather than what you think they need to do, and try and flip it constantly, so that you're talking in terms of their needs rather than what you as an innovator, are trying to sell. Really important. Have a clear aim. This is good, project management, change management practice, but I think it applies, to you as innovators too. What is it that you're trying to do month on month, quarter on quarter, year on year? Set yourself some challenging targets and then put some activity plans in place to make sure that you're striving towards that. Really important. Make sure that you keep bringing yourself back to that. And then finally, how are you going to do it? On the comms side of things, do people want to see evidence and papers? Clinicians normally do. Commissioners, senior managers that make decisions about business cases, they might be grabbed by a story that resonates with them more. I've been in meetings lots of times where people are chewing the cud and arguing with each other over the whys and the wherefores of evidence, but people can't really argue with a good patient story when it comes to selling the virtues of something. So make sure that you've got some good examples of where your product benefits a human being, because that can bring people's attention back to the important stuff, away from the business cases and the evidence. So that's that many ways to many, really. Think properly about the activity and how you're going to convince people to move along that curve from, being aware of something, having their will built, and then ultimately changing people's behaviour. Really important. Keep being creative. Will, you must have added this.
Thanks.
This sounds up your street. Working with people, taking different ideas.
Maybe I did that.
I'm certainly not the creative one. Will's the creative person. Different approaches will work for different people. Really important. Try and do what you can. Think differently. Don't be disheartened by knockbacks. Go away, dust yourself off, come back with a new way of trying to tackle the problem. I think that's it, Will.
Absolutely. Feedback, isn't it? Thanks so much, Stuart. That's brilliant. Well, that really brings us towards the end of the session now, and the end of these last 3 sessions. Oh, might you have that slide, Stu? I'll share my screen again right then. So that sort of brings us right at the end. Make sure I've got the right one. No, dear. Computer says no.
Sorry, Will.
Well, there's a last slide there that we'll send out to you. It just has a few links to our website. I think I put it into the chat box to Pathfinder at. So if you want to directly engage the NHS and have a 30-minute, 40, usually a 30-minute chat to begin with, just to get a sense of what you're doing, we have a triage form that is standard across all 15 NHSNs now, which means if you want to engage somebody up in Yorkshire in an NHSN there, you only need one form to do so. And so please directly engage us to have a conversation. But if you're an SME or an innovator and you're part of the Smartline programme, and you feel that actually you really want to spread and scale, and this is the kind of direction for you, this isn't going to be relevant for everybody, we totally get that. But for those that have ambitions to scale their product, then we're going to be working with Emma, and we're going to work with James and the team, the brilliant Emma and James, and we're going to offer a programme of support which will be longer than this to a select group of organisations, and we'll be offering that a number of times over the next 3 years. So really excited to work with you, Emma, and the team. If you want to find out more about the Smartline programme actually as well, you're quite new to it, then you can go onto the website there as well and get a bit more information. Emma, do you have any final words, reflections from yourself? Put you on the spot.
No, thank you very much, Will, and thank you. It's been really exciting doing these sessions, but just to reiterate what Will's saying is we are going to be doing kind of larger workshops based on the 3 themes of these webinars. We really want to do them face to face, so we've been holding back because obviously with this pandemic we're in, because we do feel that kind of face to face, especially in these workshop sessions where you can have one-on-one conversations about your individual needs. So we are hoping, we're just waiting to see what happens, but if you do want anyone here who hasn't been engaging in the Smartline project, do get in touch with us. I've put the link to the website in the chat box. It's Smartline, but we're here, you know, and we can, like the South Academic Health Aren't Network, we can kind of do that diagnostic with you and see how we can support you. And if we can't support you, we can signpost you to lots of other support in Cornwall. But just to reiterate, for Smartline, you do have to be based in Cornwall and the Isles of Scilly, although there are creative, like linking you with other enterprises within Cornwall to try and get innovation if you both have a similar ambition. But thank you for everyone coming today.
Thank you, and thank you, absolutely, and say that again. Thanks for everybody for joining these last 3 sessions, or new people today, and hopefully it gives you a taster of what to expect going forward. Thanks, Stuart, and you'll get a minute, if you've got a minute between your next Zoom session, yeah, wish you all the very best for this week and speak to you soon.
Thank you all.
Thanks, everyone.
Bye-bye.
See you later, everybody.
Bye.
Bye.